incidence of excessive or abnormal bleeding was first recorded hundreds of years ago. In 1803, a man named John Otto was the first to publish an article recognizing a hemorrhagic bleeding disorder that primarily affects men. John Otto, a Philadelphia physician, recognized or has called these males as bleeders. And then in 1828, a student from the University of Zurich named Friedrich Haupt, along with his professor named Dr. Schonlein, were credited for coining the term Haemophilia, which is then later on known as Haemophilia, a shorter version of, or a shorter term for the word Haemophilia describing the disease or the disorder. Good day to all of you. I am Arlene KB Morado along with my partner.
I am Cheryl Dacer, a third-year student nurse from Section B.
And today we will be discussing hemophilia. Hemophilia is also known to us the royal disease. Now you might wonder why hemophilia is known as the royal disease among all the other diseases. This is because hemophilia affected the royal families of England, Germany, Spain, and Russia in the 19th and 20th century. So let me give you a bit of a trivia. So it is believed to have started with Queen Victoria of England. So she is believed to be a carrier of hemophilia B, but of course she was unaware of it because none of her ancestors had a history of bleeding disorders. So it all started with her, and then the trait has been passed on to 3 of her children. So one male and 2 females. We have Leopold. The Duke of Albany died from hemophilia at the age of 30 due to a minor fall, which eventually resulted to a brain hemorrhage causing his death. And then the 2 daughters, Beatrice and Alice, the 2 had been married or had an intermarriage with the royal families of Germany, Russia, and Spain, therefore spreading the disease. So the disease was believed to have lasted for about 3 generations after Queen Victoria had died. So that is how hemophilia was spread throughout the royal families, and that has been known to have affected them. So it is now known as the royal disease. Now a question may arise. Why is it that only Leopold, the male son, died from hemophilia while the 2 females became carrier and was even responsible for spreading the disease throughout the royal family? This is because hemophilia is inherited as an X-linked recessive disorder. What does this mean? It means that it is a disorder that is associated with the genetic mutation of the X chromosomes. So this is why hemophilia is almost exclusive to men and more on women being only carriers or females being carriers of the disease. So let me explain this. Let me break this down. So females have 2 X chromosomes and males have only 1 X chromosome. So let's visualize that there is parents, a mother and a father, and so they had 2 offspring, 1 male and 1 female. So let's say that the mother is unaffected, but then the father is affected by hemophilia. So passing down the gene to the offspring, the female and the male. So the male have only 1 X chromosomes and then the other one is Y. And then, so if the father has passed the trait to the male child, since there's only 1 X chromosomes, then the male child will be affected or will show manifestations or symptoms of the hemophilia, while the daughter has 2 X chromosomes. So if 1 X chromosome has been affected or has mutated, then there's still 1 more X chromosome that is normal. So somehow this normal X chromosome balances it out, or like it serves as a backup for the other X chromosome that has been affected. So the female doesn't show manifestations or the symptoms of hemophilia, but it still has hemophilia, only they are carriers. So they can spread the hemophilia but does not show manifestations or the symptoms. But then that is not always the case. That is not always the case because there is a rare phenomena that occurs in which there is an inactivation of 1 X chromosome in females. So this is called the skewed X inactivation, in which for example, a female that is affected with hemophilia. So there is the mutated gene and the normal gene. So this skewed X inactivation inactivates the normal X chromosome, therefore resulting the mutation or the mutated X chromosome becoming more active than the normal one. So when this happens, in these kinds of cases, the female also shows manifestation of the disease because the normal X chromosome has been inactivated, although it happens rarely, and this case is also random, so it might not always happen. That is why hemophilia is almost exclusive to men. So, hemophilia is a hereditary bleeding disorder that is usually a result of a dysfunction or a deficiency of a coagulation factors. So we have two major forms of hemophilia. We have hemophilia A and we have hemophilia B. So hemophilia A, this is the deficiency of factor 8 or the anti-hemophilic factor. And then hemophilia B is the deficiency or the dysfunction of the factor 9 or the Christmas factor, which is why hemophilia B is also known to us the Christmas disease. This is because it affects the Christmas factor. So among the two, it is hemophilia A that is more common. You might wonder why hemophilia is more common. This is because factor 8, the anti-hemophilic factor, is more larger and is much more complex than factor 9. Therefore, it is more susceptible to mutations, to replication error. That is why hemophilia A is more common than hemophilia B. So let us learn more about hemophilia with our pathophysiology.
Today we're going to explain the pathophysiology of hemophilia. So the process begins when a blood vessel is damaged or an injury causing the blood vessels damage. The body detects this injury and triggers a mechanism to stop the bleeding. After the injury, the blood vessels undergoes the vasoconstriction, meaning it narrows to reduce blood flow at the site of injury. This immediate response minimizes blood loss and allows the next step to occur, which is the primary homeostasis. Primary homeostasis involves the Willebrand factor to form a temporary plug, which is the platelet adhesion. The platelets stick to the damaged vessel wall, aided by the von Willebrand factor. Once attached, there's a platelet activation, which is the platelets release chemicals like the ATP, thromboxane, then serotonin that signal other platelets to join. Then platelets clump together, forming a temporary platelet plug. In hemophilia, this step happens normally. However, the temporary plug cannot be stabilized because of the deficiency in clotting factors needed for fibrin formation.
So let us now go to the secondary hemostasis. Hemostasis, by the way, is the process in which the body stops the bleeding. So secondary hemostasis, this is the process in which the body forms a clot through the activation of the coagulation cascade. So the coagulation cascade involves the coagulation factors. So there are a lot of coagulation factors that we will be tackling later. So in this secondary hemostasis, we have the activation of the blood proteins or the coagulation factors. So in the coagulation cascade, we have two initial pathways, the intrinsic and the extrinsic pathways. First, let us focus on tackling the extrinsic pathway. So the extrinsic pathway, this is responsible or crucial for the generation of thrombin to stabilize the platelet plug that has been created in the primary hemostasis. So this extrinsic pathway is called extrinsic because it is initiated by factors that originates outside of the blood. So this factor is namely the tissue factor or the factor 3 or the thromboplastin. So this thromboplastin is the main initiator of coagulation. That is why it is normally hidden from, it's not present on the surfaces of the cells or the endothelial cells because it is hidden to prevent unwanted clotting. Because it could lead to thrombosis. So it is also the target of anticoagulation meds. The main initiator is the thromboplastin or the tissue factor. So this tissue factor is the one that binds with the factor 7 or the stable factor, activating it to the factor 7A or this activated stable factor. So it binds together, as this factor 7 is important as it is crucial for the rapid initiation of the coagulation cascade. So once binded with the tissue factor, they form the tissue factor and the stable factor complex. So now this complex binds with factor 10. So once they bind with factor 10, this complex cleaves the factor 10 to its activated form, or the factor 10A, in which this leads to the generation of thrombin. That is how the extrinsic pathway works. Now we will move on to the other initial pathway of the coagulation cascade, which is the intrinsic pathway. So the intrinsic pathway amplifies the coagulation process that has already been initiated by the extrinsic pathway. So as you may remember, it is the intrinsic pathway that is crucial for the generation of thrombin to stabilize the platelet plug that is formed in the primary hemostasis. So the intrinsic pathway, the job that they do is they amplify the coagulation process that has already been initiated by the extrinsic pathway. So the intrinsic pathway involves the activation of the coagulation factor 12, or the Hageman factor. So the Hageman factor is activated, it becomes the factor 12A. So now this factor is activated by negatively charged surfaces. So once activated, they serve as amplifying factor. They amplify the coagulation process by activating factor 11. Factor 11 is also known to us the plasma thromboplastin antecedent. So this thromboplastin antecedent, this factor is important, or is crucial to ensuring that there is sufficient production of thrombin, or sufficient generation of thrombin for the stable clot formation. That is the job of the factor 11, or the plasma thromboplastin antecedent. It also activates factor 9, or the Christmas factor, in which this factor 9 serves as, or is crucial for the rapid generation, or the rapid initiation of the coagulation process. So by doing that, the factor 9 binds with factor 8, also known to us the anti-hemophilic factor. So this anti-hemophilic factor serves as a cofactor for the factor 9. So they bind together in order to form a certain complex, so-called the intrinsic tinase complex, in which this complex is the one that activates or catalyzes the formation of thrombin by activating the factor 10, or the factor 10A as its activated form, the Stewart-Prower factor. So as you've noticed, both intrinsic and the extrinsic pathway ends with the activation of factor 10. This is because the activation of the factor 10 is where both pathways converge. So this convergence leads to the formation of another pathway, so-called the common pathway. So this common pathway is the final phase of the coagulation cascade, in which also involves factors leading to clot stabilization. The common pathway involves the activated factor 10 as well as the activated factor 5. Factor 5 is also known to us the labile factor. So this factor enhances the catalytic activity of the factor 10. This serves as the cofactor in forming the prothrombinase complex. So the factor 10A and the factor 5A, or the activated Stewart-Prower factor and the activated labile factor, combines, forming the prothrombinase complex, in which this complex activates the prothrombin, or the factor 2, to its activated form, which is the thrombin, or the factor 2A. So it catalyzes the conversion of prothrombin to thrombin. Prothrombin serves as has a central role in the coagulation cascade, or the coagulation process. The prothrombin is then converted to thrombin, in which thrombin becomes responsible for the cleaving of fibrinogen to fibrin. So cleaving is the process in which, like, something breaking down of peptides or chemical bonds. So the thrombin breaks down the fibrinogen to fibrin. So fibrinogen is a large rod shaped like glycoprotein that is composed of three chains, or the polypeptide chains. We have 2 alpha chains, 2 beta chains, and then 2 gamma chains. So these chains is linked together by a so-called disulfide or disulfide bond, so making it having a complex structure that is then cleaved by the thrombin. So this cleaving, once done by the thrombin, the thrombin cleaves the fibrinogen to fibrin. So once there is the cleavage, or once the cleaving is done, the fibrin forms the so-called fibrin mesh, in which this mesh can be visualized as something like a net that holds together the platelet plug that has already been created in the primary hemostasis earlier. So this fibrin mesh, once there is a formation of this fibrin mesh, there is clot retraction. Clot retraction is basically the process in which the clot contracts. Therefore, the clot shrinking, or there's a change, or when there's contraction, there is a change in the size, making the clot smaller, also bringing the edges of the damaged blood vessel together, therefore facilitating healing. That is the clot retraction. And then once clot retraction happens, of course, there is also stabilization. Stabilization is to prevent the clot from dislodging or displacing from the injured site, making it stay there for a while. And then of course, when there is a stabilization, there's also resolution. Resolution is also known to us as fibrinolysis, which is the process in which the clot breaks down when the blood vessel is healed. That is the stabilization, the clot stabilization, and resolution.
Once the blood vessels is healed, the clot needs to be dissolved to restore the normal blood flow. Fibrinolysis occurs where the plasminogen is converted to the plasmin, breaking down the fibrin mesh into fragments. Although the fibrinolytic process may still function, the initial clot is too weak to stabilize, leading to excessive bleeding. Now is the platelet factor. Platelets play a significant role by releasing the chemicals that regulate clot formation and healing. So first is the platelet factor 4, or the PF4, which helps control thrombin activity. The platelet-derived growth factors encourage tissue repair and wound healing. And the ADP and serotonin recruit more platelet and assist in vasoconstriction. Now, what happens when the patient has hemophilia? So here are the modifiable and non-modifiable factors. Modifiable factors are bleeding risk management, medication, prophylactic treatment, diet and exercise, vaccines, lifestyle, and then the non-modifiable factors, the genetic mutation, family history, sex, and age.
Disrupts the secondary hemostasis. Remember, in the secondary hemostasis, it involves various of the coagulation factors, right? And each and every coagulation factor is important because each and every factor activates another factor. So hemophilia A is the deficiency or the dysfunction of the factor 8 or the anti-hemophilic factor, and then hemophilia B is the dysfunction or the deficiency of factor 9 or the Christmas factor, and then hemophilia C is the deficiency or the dysfunction of the factor 11 or the plasma thromboplastin antecedent factor. So a patient has hemophilia C or the hemophilia C affecting the factor 11. So factor 11 activates factor 9. So if there is deficiency or dysfunction of the factor 11, it will not be able to activate factor 9. Therefore, when there is no activation of the factor 9 will not be able to bind with factor 8. And then factor 8 and the combination of factor 8 and factor 9 creates the intrinsic kinase complex, right? So if there is no combination of the two, there is no intrinsic kinase complex, and there is no activation of the factor 10, which generates thrombin. So therefore, causing impairment in the blood coagulation, prolonging bleeding if there's ever an injury. So that is what happens in hemophilia. So in each and every disruption or each and every deficiency of coagulation factor, it causes the signs and symptoms that will also be discussed by Ms.
Signs and symptoms of hemophilia are excessive bleeding, hemarthrosis, muscle bleeding, prolonged bleeding after surgery or dental work, easy bruising, blood in stool and urine, epistaxis, intracranial hemorrhage, and then potential signs and symptoms, excessive menstrual bleeding, and postpartum bleeding.
So now we move on to the nursing diagnosis of hemophilia. So we have here 6 nursing diagnoses of hemophilia. First, we have the risk for impaired skin integrity. So bruising, cuts, abrasions as well can occur very easily due to the increased fragility of the blood vessels. So this can lead to complications such as bleeding under the skin. And then we also have risk for infection due to repeated infusion of clotting factor replacement. So this repeated infusion can lead to infection if not taken care of properly. And then another nursing diagnosis is acute pain. So hemarthrosis, which is bleeding in the joints, is associated or is a complication of hemophilia. So this could this could be caused by microtrauma, but since there is a impaired clotting in the patient's body, therefore it causes bleeding, or prolonged bleeding, causing significant pain as well as swelling in the patient. So it can also lead, hemarthrosis can also lead to impairing the mobility of the patient. Therefore, one of the nursing diagnoses for hemophilia is in risk for impaired mobility. But it only occurs in severe forms of hemophilia. And then we also have deficit knowledge, in which families and the patient could have a lack of knowledge about hemophilia, its management, as well as interventions. And then there's also risk for anxiety, since of course there is a lot of treatments, a lot of medications for the patients to take, a lot of things that they should be careful of, so it could lead to emotional distress and anxiety. And so the nursing interventions will be discussed by Ms. Dacer.
Intervention: monitor for signs of bleeding, educate the patient and family on avoiding high-risk activities and using protective gear, assess and monitor pain intensity, location, and character, administer analgesic as prescribed, and apply ice pack to affected joints to reduce pain and inflammation, encourage rest and avoid movements that might worsen bleeding, encourage physical therapy and range of motion exercises to preserve joint function, reinforce safety measures to prevent falls or other injuries that could cause skin tears, educate the patient on gentle skin care and use of soft bristled toothbrush, monitor for signs of infection, ensuring good hand hygiene and aseptic technique are followed during infusion, and provide information on hemophilia, including the importance of regular factor replacement therapy and signs of bleeding. Laboratory exams includes screening tests, complete blood count or CBC, activated partial thromboplastin time or APTT test, prothrombin time or PT test, fibrinogen test, prolonged activated partial thromboplastin time or APTT, and then the clotting factor test. Prognosis: so with proper treatment, people with hemophilia can lead relatively normally lives. However, untreated or poorly managed hemophilia can lead to complications such as severe joint damage or hemophilic arthropathy, disability or life-threatening hemorrhage. Advance in factor replacement and gene therapy have significantly improved outcomes.